Alrighty, so now we're going to be learning about peripheral artery disease, or PAD, specifically of the lower extremities. So PAD is very strongly linked to other cardiovascular diseases and has very similar risk factors. So we're going to see a lot of repetition in this chapter. So atherosclerosis is a leading cause in the majority of cases of PAD, just as it is in coronary artery disease. So atherosclerosis and coronary artery disease involves the coronary arteries, and atherosclerosis and PAD involves the peripheral arteries. So PAD is fairly common. Unfortunately, it's underdiagnosed and undertreated. There's not a lot of public education done about peripheral artery disease, but there is a lot of public education done with coronary artery disease. So this picture shows that people can have several different areas of lesions or atherosclerotic lesions, just as many people do in coronary artery disease. And patients don't start to have symptoms, clinical symptoms, until those arteries are 60 to 75% blocked. So most patients don't become symptomatic until their 60s to 80s. And our risk factors are very similar to coronary artery disease risk factors, such as cigarette smoking, hyperlipidemia, hypertension, and diabetes. So for clinical manifestations of PAD, the most classic symptom is called intermittent claudication, which is ischemic muscle pain that's caused from a constant level of exercise. It resolves with rest, but is reproducible. So if I go and exercise again, that pain will come back. This is very similar to chronic stable angina. So with intermittent claudication, if I go for a walk and 15 minutes into my walk, because I'm walking uphill, I have this leg pain. I sit, I rest, that leg pain goes away, but tomorrow it does the same thing, so it's reproducible. So that intermittent claudication was the primary symptom, which is the pain with activity. But other clinical manifestations are paresthesia, which is the numbness or tingling in the toes or the feet. It's due to ischemic nerve tissue. It produces a loss of pressure, deep pain sensation, kind of very similar to the numbness or tingling that diabetic patients would have. A really big problem for this is that injuries can go unnoticed by the patient, and we'll go through some of the teachings that are definitely needed because of this paresthesia. Sometimes patients can have pain at rest, and most of the time it's due to decreased blood flow. So if I elevate my limbs or elevate my legs with PAD, I'm not going to have good, gravity's going to be working against me, and I'm not going to be having good blood flow to my feet. And decreased blood flow, we don't get oxygen to our tissues, we change from aerobic to anaerobic metabolism, lactic acid builds up, tickles our little nerve fibers, which does not feel good, and that's where I get pain from, right? So it usually occurs at night because we naturally have a lower cardiac output when we're sleeping. So sometimes patients wake up with PAD with pain in their legs, and it's due to ischemia. However, they have the legs that I have always wanted. Thin, shiny, taut skin, loss of hair on the lower legs. Holy moly, things look good. But honestly, this is just due to decreased blood flow. Oftentimes they do have diminished or absent pedal pulses. So despite the thinness, you would expect to find those pedal pulses pretty readily. But you cannot, because with PAD, naturally we have obstructive blood flow. And then I have this thing called the Buerger's test, Buerger test. And this is when I elevate my feet will be pale. So pallor of the foot with leg elevation. And then when I go to dangle my feet at the bedside, because I will have more blood flow, I have this reactive hyperemia, which just means my feet turn red, with the dependent position, which is dangling at the bedside. And that's the Buerger's test. So if I elevate them and they turn pale, it's positive. And if I dangle them at the bedside and they turn red, it's positive. Just a quick and easy way to see if somebody, has some claudication going on, atherosclerosis. So those legs that I have always dreamed of, the thin, shiny, taut skin, it's actually due from atrophy of the skin and underlying muscle. And that's the reason why their legs are often so thin. Delayed healing, wound infection, tissue necrosis, and then arterial ulcers can be common as well. So arterial ulcers are usually present on the lower extremities, especially on the tops of the feet or on the toes. And they can go unnoticed, especially if they have, not the ability to check out their feet, the inability. Usually these ulcers occur over bony prominences. They have very well-defined edges, so they're very circular, as opposed to venous ulcers, which seems to have like a jagged edge. They're just not very well-defined. Arterial ulcers are well-defined. They're typically painful at night because of the decreased perfusion that we have at night or with leg elevation. However, they don't really bleed much, and they're pretty deep. So venous ulcers, are superficial. Arterial ulcers are a little bit more deep, but arterial ulcers do not bleed as much or weep as much as our venous ulcers. And again, that's because we don't have that good blood flow going to that area, and it's not likely that we have edema like we do in our venous ulcers. So just like we have collateral circulation or the development of new blood vessels around an area of occlusion with coronary artery disease, the same thing develops with PAD. So if we have progressive narrowing of arteries over time in our periphery because of the atherosclerosis, we get collateral circulation in our legs as well. If that collateral circulation is not sufficient, or if there's atherosclerotic lesions that build up over time, we can lead to some complications. So some of those complications are non-healing arterial ulcers, and sometimes these become very gangrenous and result in amputation, especially if the bone is infected, the osteomyelitis. That is usually not a very good sign. And patients wind up with amputations. So there are several diagnostic studies to help confirm a PAD diagnosis. So some of the ones you might see, other than our decreased pedal pulses, is a Doppler ultrasound. So they'll get segmental blood pressures, which means that they'll take blood pressures in your arms. They'll also take them in your thigh, calf, ankle even. And your lower leg blood pressures should be pretty similar to your arm blood pressures. So that'll determine the difference there to see if there's any blockages or any extreme difference. Then there's the ankle brachial index, or the ABI, where they'll do your brachial or your arm blood pressure, then they'll do your ankle blood pressure, and they'll determine the ratio between them. So we'll divide the ankle blood pressure by whichever arm is higher, and you'll come up with a ratio. So depending on that ratio depends on whether or not, you have the severity of your PAD. Those are generally done in the office setting. You don't see those done in the hospital because they're for diagnosis of PAD. And then, of course, angiography and MRIs or MRAs, they can determine the location and the extent of your peripheral artery disease. And the same with duplex imaging, which is just color Doppler. They can also determine location and the extent of the atherosclerotic lesions. So our risk factor modification is huge. We want to prevent against PAD. So a lot of these risk factors, or these risk factor modification, is going to be the same as our cardiovascular disease, such as smoking cessation, aggressive treatment of hyperlipidemia, including diet and exercise and anti-lipemic agents, maintaining blood pressure, and then controlling our diabetes as well. Unfortunately, our diabetic patients, we see more amputations in those patients that have that dual diagnosis of diabetes and PAD. So really encouraging a more healthy lifestyle for those with this diagnosis. All right, so let's talk about some medications that patients might be taking to help with PAD. So ACE inhibitors are fairly common because they increase the blood flow because they vasodilate to the periphery, which helps with a bunch of different things. It helps with symptoms, it helps with walking, and exercise is very important for these individuals because what did we learn about collateral circulation? Actually, exercise can improve our collateral circulation. So we want patients walking. So ACE inhibitors will help them tolerate that activity a little bit more and perfuse their periphery. And then the next, just as with coronary artery disease, patients often are taking antiplatelets. So whether it be aspirin or clopidogrel, it depends on whatever is prescribed. They don't need both of them at the same time, but generally just one or the other. And this is not to be confused with our anticoagulants, right? Which are our warfarin, our Xarelto, and our Eliquis. So they don't need to be on anticoagulants, but they do need to be taking antiplatelets. And then we have two specific medications that are meant to help treat the symptom of intermittent claudication. So the first is cilostazol. It's actually an antiplatelet, and it's a vasodilator. So this is usually the first line medication that's used for those patients who don't respond well to exercise therapy. So sometimes when patients have intermittent claudication, it improves with exercise, but this is taken for patients who exercise, it does not help for them. The second drug here is pentosyphyllin, and that decreases blood viscosity. It's a xanthine derivative, and it helps blood vessels, or excuse me, it helps erythrocytes or red blood cells, kind of squish through the vessel. It makes those erythrocytes more flexible. So we're able to get increased blood flow to our periphery because those blood cells are more flexible and they can kind of squish through some of that, the plaque buildup. They can flow through easier. So in short, it treats muscle pain by increasing blood flow through the periphery because it allows for red blood cell flexibility. So supervised exercise via rehab, sometimes cardiac rehab, is really important for these patients. So unfortunately, the more pain that we have when walking, the less we're going to walk naturally, right? The weaker the muscles get, the harder it is to walk, and the more progressive PAD can get. So our goal is to have patients exercise for 30 to 60 minutes daily, 3 times a week, without having those symptoms. So in this exercise program, let's say I have really bad intermittent claudication and I can only walk for 5 minutes. I will gradually increase my activity until I can walk my 30 to 60 minutes. So we don't want patients walking through their pain. So if I can only tolerate 5 minutes of walking, I will walk, I will sit down, wait for my pain to subside, I will get back up and I will continue my brisk walking again until the pain starts. I will sit down, I will rest and keep going until I hit whatever my target may be of 30 to 60 minutes of exercise. So we don't want patients walking through their pain because the pain is ischemia. So we don't want patients more ischemic, but we do want to increase their activity. So just to clarify with that. So this is supervised exercise again, just as we would see with our CAD patients. Maintaining a healthy body weight is important, and also having a diet high in fruits and vegetables and whole grains, low in cholesterol and saturated fat because it helps with we don't want any increased in our atherosclerosis, right? And then we also want to have a low salt diet because we want to decrease our risk for hypertension. So PAD can be treated with medications and exercise therapy, but it can also progress. So if I have progressive PAD, it is given this term critical limb ischemia, and this is when patients require some sort of surgical intervention. There's something more than just exercise therapy and medications. So the definition of critical limb ischemia is chronic pain at rest for more than 2 weeks or ulcers or gangrene due to PAD that are not healing. I do not like the term that they use, critical limb ischemia, because it makes me think that they're coming in and like their limb's about to fall off, but that's not the case. So don't let the name fool you. It's just a more progressive PAD because now they're having pain either at rest or they have some ulcers or gangrenous areas that are not healing. So some of the care that we do is obviously protect that limb from any sort of trauma. So make sure it's wrapped really well in gauze if that's an indication. No flip-flops, making sure patients wear shoes all the time. Measures to decrease the pain, which would be dangling the legs, right? We don't want to elevate these patients' legs because that would increase the pain. Preventing and controlling infection in those areas, and especially trying to prevent osteomyelitis to preserve their limb. And then we have these other strategies that are aimed at controlling pain that we get with our critical limb ischemia. So spinal cord stimulation, or a spinal cord stimulator, is a little implantable device that is placed subcutaneously. It kind of looks like a pacemaker. That's what it reminds me of. So there's this little device, which is called a pulse generator. And then this pulse generator has this wire that comes out of it, and it is basically placed into your nerve fibers, into your spine. And that helps kind of defer those pain stimuli that the PAD is causing. And then we have angiogenesis, which is growth of new blood vessels. There's actually medications out there. Primarily, they're used for cancer patients, but there are medications that can help promote angiogenesis, which would help develop collateral circulation. So when those symptoms or when our PAD really progresses, when tissue is becoming affected, that is when we start talking about some of the different kinds of procedures patients can have. So let's take a look at some of those. So interventional radiology procedures are fairly non-invasive. So one of them is a PTA, which is percutaneous transluminal balloon angioplasty. So a catheter is inserted through the femoral artery, and the area of occlusion is sought, and the catheter has a little balloon on the tip of it, and it's inflated, kind of very similar to stent placement in our coronary artery disease. And once this balloon is expanded and the plaque is, smushed against the side there, a stent holds that area patent, so then a stent is placed. Other procedures are an atherectomy and a cryoplasty. Atherectomy is more ideal for areas that are difficult to stent, especially at areas where there's bifurcation. But this involves removal of the obstructing plaque using it's like a little roto-rooter. It goes in and it's like scrapes away or sucks away that plaque. Just goes in, all the plaque. Cryoplasty is using nitrous oxide to decrease cell activity. So this cold limits restenosis because of it decreasing our cellular activity. So they go in and do that percutaneous transluminal angioplasty and then with cold therapy as well, instead of the stents. And then there's more invasive surgical therapies that can be used. So this type of invasive surgery is really indicated for patients with long areas of the stenosis or plaque. So it's a peripheral artery bypass using either patient's own veins or synthetic grafts, and it's kind of like a cabbage procedure in the heart where you would bypass that vessel with a new vessel, and this is what happens with PAD. It's not uncommon for stents to also be used with this type of surgery. So this picture just shows what we went over. So depending on the area of occlusion, clearly it would be difficult to find a vein, a patient's own vein, as long as what's needed in picture B. So that's when we would use more of a synthetic graft. Sometimes they'll use both. They'll use the patient's own vein and part synthetic. But patients do need to be on dual antiplatelet therapy for about 4 to 12 weeks after this. So they'll usually be on aspirin and clopidogrel. Other surgeries that you might come across in practice are the endarterectomy, which involves opening the artery. So they dissect the artery and then remove the obstructing plaque and then sew the artery back up. This is seen with the carotid arteries a lot of times, right? There's carotid endarterectomies. So usually it's saved for smaller areas. There's patch graft angioplasty, which is opening the artery, removing the plaque, and then sewing a patch to kind of widen that area of, to widen the artery, basically. And then, of course, there's amputation, which is we always want to do everything we can to preserve the limbs. But this is needed especially if there's an infection or osteomyelitis. Since PAD is largely underdiagnosed, obtaining a health history and really looking at risk factors to help patients with risk factor modification is really important for nursing. Assessing for exercise intolerance, also looking to see how much muscle atrophy is present. Loss of hair on the legs and the feet because of decreased perfusion. And then, of course, assessing for pulses too. We always want to assess for the most distal pulses. So if I have a below the knee amputation, I would assess my popliteal pulses, right? If I had an above the knee amputation, I would assess femoral pulses. So we always want to make sure that we're still assessing the pulses. Just because I'm missing my foot doesn't mean that I don't check any of the pulses on that entire leg. So we always want to check the most distal pulses. Also assessing for temperature, cap refill of the affected extremity. That Buerger's test, right? So elevating the feet should make my feet turn pale if I have PAD. And then putting them in the dependent position would result in them turning red, that reactive hyperemia. So our goals for these patients is adequate tissue perfusion and relief of pain, whether that be a surgical intervention or maybe just exercise. It really depends on how progressive the PAD is for those patients. And then maintaining the integrity of the skin to prevent against infections and further complications. So this slide is referring to patients post-op after they have a bypass graft. So some of our assessments and or interventions that we would do for patients coming out of surgery is assessing for the skin color, temperature, presence of peripheral pulses. It is really important to get report on how somebody's pulses are. We expect them to have pulses post-op, right? That's the whole point of the procedure. But sometimes those pulses still are only present with Doppler. So we would want to make sure that we got in report how those pulses are. Many times too, they'll mark the pulses so they're easier to find. And this is done every 15 minutes. We would be assessing these bullet points here for an hour, and then it's usually hourly after that. So if they did have this type of surgery, they may go to a critical care unit for close observation, or they might go to a surgical unit. It really depends on the hospital. Continuing, for somebody who is post-op, is our circulatory assessment. We want to assess for the 6 Ps, right, which are pain, paresthesia, or numbness, pallor, paralysis, pulselessness, and poikilothermia, which is coolness, basically, of the extremity. So it's the extremities taking on the temperature of the environment because it's not being perfused. That's poikilothermia. Let's see, monitoring for potential complications. Let's go through those. Bleeding, thrombus formation, embolization, or compartment syndrome. If patients do wind up having complications after surgery, commonly it's related to that graft either clotting off, not taking. So patients will have a dramatic increase in pain. So if this happens, it's so important to really assess the extremity. I haven't sent many patients back to the OR in my practice, and the few patients that I have had to send back were, our graft patients that have peripheral grafts, just because those don't wind up taken, especially patients with really severe PAD and who have had either more than one graft placed or a really long graft. So really assessing for those 6 Ps is so important. Compartment syndrome can happen because of the swelling that occurs after surgery, and we really want to try to decrease the pressure on those sutures. So it's not uncommon for us to elevate their legs after surgery just a little bit, just to help with some of that swelling and to decrease the stress on the sutures. And it helps decrease our risk for DVTs and other post-op complications as well. Avoiding the knee flexed position because we don't want to clog off or clot off those stents, those grafts that were just placed, right? And then turning and positioning frequently to help promote blood flow. Many times patients will come out on heparin drips post-op graft just to keep that graft patent. So they are at more risk for bleeding. And walking is something that happens fairly quickly after surgery because we do want to, promote blood flow and exercise. So don't be surprised if they want those patients out of bed pretty quickly after surgery once the pain is controlled. There's that. All right, and then really risk factor modification is so important for these patients. especially tobacco cessation. So stop smoking is so important. Long-term aspirin therapy or clopidogrel, if that is the antiplatelet of choice, depending on the provider, their doctor. And also they may be on dual antiplatelet therapy for a short period of time if they've had some of those surgical interventions that we covered. So education about that. Importance of gradual physical activity after surgery. So we do want them moving some sort after surgery and really trying to increase their exercise tolerance. Importance of meticulous foot care, daily inspection of the feet, making sure patients wear comfortable shoes, making sure they check the temperature of water before placing their feet in the water, whether it be, this should be avoiding hot tubs, avoiding baths, those sorts of things. We want to try to keep the feet fairly dry. So we don't want to lube those feet up with, Vaseline and then put socks on. Anybody ever done that? I used to do that as a kid to have like soft feet. I'd put Vaseline on my feet and then socks, and then I'd go to bed. So when I woke up in the morning, I'd take my socks off and have these really soft feet. I know, weird, I know. But this is not for those patients because we don't want their feet at risk for maceration because of the, all that moisture. So we want their feet fairly dry, not to the point of cracking, but okay, I think you get what I'm talking about here. And then teaching them too how to inspect their feet and what to look for, complications to look for. All right, and then relating back to our goals would be our evaluation. And obviously we want to make sure that they have an increased exercise tolerance or activity tolerance, and that they are able to tell us about their treatment plan and their care plan. Write that teach back. And then just for reinforcement, this slide just goes over what we just talked about, having the patients really readily able to verbalize some of the key elements such as listed there.